And now it gives me great pleasure to introduce the caboose of the panel discussion folks here, and that is our absolute genius and innovator of the ZAGA concept itself, Dr. Carlos Aparicio. Has been a very great personal friend and colleague for so many years. Can't say enough about him from a human perspective, the absolute epitome, in my humble opinion, of solid core values and humility, including humility at the ultimate, if you will, core value. At any rate, a super person, a super clinician. He graduated summa cum laude in medicine and surgery in 1978, received his dental degree in 83, and subsequently, many of us may not know this, but is a well-accomplished dental lab technician. That was in 83. And if that wasn't enough, he continued on and obtained a diploma in implant dentistry at the University of Gothenburg, Sweden in 84, a master's degree then in science of materials at Polytechnic University in Barcelona in 1990. And then on top of that, received his diplomat status in periodontics at the University of Gothenburg in 92, and then a master in biomedical research university of Barcelona in 2010, and finally a PhD summa cum laude at the University of Barcelona School of Medicine. I could go on, but wow, what more can I say about this gentleman? He's editor of course, the classic book, Zygomatic Implants, the Anatomy Guided Approach. And he's also a fellow researcher within the Handicap Research Group in the Department of Biomaterials at the University of Gothenburg. Again, an accomplished clinician, master clinician, absolutely yes. Extensive experience with the Zygomatic implant would be an understatement for sure. And again, being part of so many different organizations, especially the EAO, for a number of years, and founder president of the Spanish Society of Minimally Invasive Dentistry. I can go on and on and on, but let me just get right to the heart of this entire format, and personally want to thank you, Carlos, for putting this together. You and your team should be commended for an outstanding format, especially the fact that we can do this virtually. Very impressive. We can reach our global colleagues in a very nice and efficient format. So with that said, it's a pleasure and an honor to introduce you now as our final panel speaker, Dr. Aparicio.
Thank you, Mike. I was here listening to you, and then my heart started biting. So it's nice always to have some extra power, extra adrenaline. And yes, it's really a pleasure and honor to share this podium with all of you, even though it's an e-podium. I like to state also now that I'm working here in Barcelona. I was able to solve my office. I am a free bird, and our Science Center headquarters is here in Barcelona at the Hepler Bone Clinic, where we have a department for zygoma-related rehabilitation. This is the only implant treatment I do now. So this is the only dentist treatment I do now. Hopefully, I'm very, very concentrated to the zygoma-related oral rehabilitation. Today, we are going to talk a little bit more about the coronal entrance of this implant. I'm going to discuss with you about which anatomical criteria we are going to use, and then for that I will use some cases. Since the release of the news of the new implant are already on the air, I will use my presentation also to present cases and also to present the rationale for this new portfolio of implants. But beforehand, I would like to introduce you, which is the clinical scenario we have now. We have a patient showing a very, very resolved maxilla and atrophied maxilla with almost no bone over there. So this is a maxilla that is not able to withstand regular implants. And this is our challenge. Our goal is to fix a set of teeth as much natural as possible, to as much closer to the nature as possible, fix teeth, I said. And what are the risks? I'm not talking I'm not going to mention about surgical risk. I'm going to mention about late risk, the risk that will appear a couple of months later, 6 months later, 2 years later, as we have noticed during those presentations. Those are the risks of fistula. Oroantral fistula can be sinus or nasal fistula, and also the risk of soft tissue deficiency, the soft tissue incompetence, soft tissue infection, soft tissue inflammation. So we have to balance those two main risks in order to choose which one we prefer to face first and which one we prefer to face later, because the challenge is this atrophic maxilla where we don't have any other possibility. So I would like to first show you those 1, 2, 3, 4 patients in order to explain that this patient is absolutely different from that one, and from that one, and from that one. So I'd like to mention some questions, to address some questions about where to place the coronal entrance of our zygomatic implants. Always we should use the same position. Should we go always intrasinusal, or should we go in a different way depending? Does exist a clear parameter to decide how to proceed? Or can we talk about sinus entrance? Where are we going to place the anterostomy, the sinus entrance? Are we going to place it on the crest, upper? Where? So we will discuss about that also. And the final question I would like to address is, what is the importance of sinus lining? Should we preserve sinus lining, or we shouldn't, or we don't care about that? And this, without forgetting many other factors like that may influence in the final result. And we will refer to those other factors too. So I think I prefer to refer not to the coronal entrance, but the coronal implant positioning, because maybe the implant is not going to pierce the coronal part of the sinus. So let's talk about coronal implant position. Which criteria do we have for that? We have, or we should use, excuse me, prosthetic criteria. We should use biomechanic criteria, but today we are going to concentrate just on the anatomical criteria, anatomic criteria. With this anatomical criteria, we are going to perform our osteotomy. And when we take the drill in our hands, this is going to be an irreversible procedure. So previous to drill, we have to think, what are our osteotomy goals? What do we want? And I think we can resume this in 3 procedures, in 3 goals. The first one could be to avoid soft tissue recession. I'm so happy you have mentioned about soft tissue recession. Second one, that I'm also happy it has been mentioned during the previous lecture, is about maximize alveolar bone to implant contact. And the third one is about how do I preserve my sinus? How do I avoid sinus fistula? And all of this can be resumed in our what we call ZAGA minimally invasive osteotomy. Our patient is suffering from what? Our patient is suffering from extreme maxillary atrophy. That's the problem for patient. Extreme atrophy of the maxilla. So I should try not to take out too much maxilla, because the problem of this patient is absence of maxilla. The more conservative I am, the better for my patient. So the first goal we said is to avoid soft tissue dehiscency, to avoid this kind of problems. Can you see that? Those implants probably are going to be very stable on the apex. Look at this. This is soft tissue dehiscency. This is soft tissue incompetence, soft tissue inflammation, soft tissue infection. So that's a failure, my friends. How we avoid that? And for that, I ask you to think. Let's raise our first question. Does implant head position influences soft tissue maintenance, and why? It is the same, this implant position, than that one? Which implant position do you think is going to be more dangerous for the soft tissue? That one, the left, or the right? You know what? You know that this implant that is placed outside of the bony envelope is going to compress soft tissue, is going to compromise soft tissue vascularity. And then it may provoke, and we have to force it right now, at the moment of the surgery, it may end up in a soft tissue problem. Whereas that implant has still some bone left over there. So I don't expect to have soft tissue problems on this implant. And there is our first message. The risk for soft tissue dehiscency increases in extramaxillary techniques. We have to have this in our minds at the moment of the surgery, because it's the moment to prevent it. We force it and we prevent it. So why the remaining bone at the maxillary should be eliminated, as some authors state? Why we should take out this bone? This bone is marvelous. It's marvelous because this bone will allow soft tissue connective fibers to attach in. So this bone is going to avoid soft tissue dehiscency. So this is our measures number 2. Please do not discard alveolar remains in extramaxillary techniques. Do not discard this bone. This is a treasure, and we have to preserve it. We have to maintain it. Our second goal, we said, is about how to obtain maximum bone-to-implant contact at this alveolar part. First of all, we should do that because the more we sink the implant, the less vascular compression we produce. The less we are going to jeopardize vascularization of the soft tissue. So the less risk we get for soft tissue dehiscence. And also, the more contact we have, the most bone-to-implant contact we will end up with this implant. I'd like to introduce you these 2 studies of Friedman and co-workers of finite element analysis, where they place implants and they compare implant placement with precise placement, and then they make like a hole around the implant in both in the intramaxillar intrasinus implant place and also in the extrasinus. So at the end, the implant was not surrounded by bone, and they compare the implant perfectly surrounded with bone with the implant that is not surrounded with bone. Their conclusions show that alveolar bone support for zygomatic implants plays, no matter if an intra or extrasinus position, reduces the internal stresses that are generated by occlusal and lateral forces. So please, the more bone to implant contact we get, the better. And this is our measures number 3. Maximize alveolar implant contact, no matter if you plan for intra or extrasinus plasma. So now we go to the long-term sinus maintenance. Think of that. We were taught to pierce this sinus through this very, very thin alveolar bone. What do you think is going to happen with this bone? I tell you, in few months or years, this patient will use a very hard toothbrush, or he will bite or she will bite water pick element, and he will destroy the soft tissue ceiling, which is very weak, as you know. And then she or he will expose the connective tissue covering the bone, and this bone is going to resorb, and the fistula is going to be created so easy. Or if not with the soft tissue, or if not destroying with the oral hygiene procedures, maybe he or she will go to a dentist, and the dentist will take his dental proof, and he will proof around, and he will destroy the connection, this weak hemidesmosomal connection of the soft tissue, and then they provoke again this connective tissue to be exposed to the oral cavity, and bone will disappear. So our ZAGA concept is based on what we call patient-specific zygomatic therapy. Patient-specific. Patient-specific means that we are going to analyze the bone of every patient, and then we will decide our protocol according to this bone. But before explaining or talking more about that, I would like to introduce you a very simple 2 concepts. I would like to introduce you the tunnel concept. This is a tunnel, okay. A tunnel is like a hole we make on the ground or wherever, and has some characteristics. And the main characteristic is it does a floor, it has lateral walls, and it also has a roof. A tunnel has a roof like that. So let's make a tunnel on a plastic model. You see, we have a roof, we have a floor, and lateral walls. Is circular. Tunnel is circular. And how do we close a circumference with another circumference? In contrast, a canal also has a floor, has lateral walls, but it has not a roof. So this is a canal I made in a plastic model. As you may see, we have lateral walls, can be higher or lower, but we have lateral walls. We have a floor, but we don't have a roof. Canal versus tunnel. Very easy concepts to get in. So now we go to a practical patient. This patient, the first question we have facing this patient is, should we go for intro or extrasinus path? Should we go for tunnel or canal? So let's think about it. And we are going to analyze this part. So let's go for the anatomy. We go to this sinus floor, we take care of the architecture, and we measure. We have more than 4 millimeters. For us, you can go through this bone, and you may stabilize an implant in this apical part on the zygomatic bone. And if this implant is stable, you will get secondary stabilization here. You will get osseointegration, and this osseointegration probably is going to be enough to permanently seal this sinus. Of course, since we got into the sinus through the palatal part, we are not expecting any problem with the soft tissue. So this is our measures number 4. Providing adequate alveolar volume and architecture are present, and intrasinus path will be chosen. It's recommended. So let's do the things as easier, as simple as possible. We have enough bone, let's go for an intra. This is for my friends, the Français. Says this is a French machine of coffee machine. This is a circular coffee machine. It's a tunnel. How do we cross this tunnel? With an embolus, with a circular embolus. So whenever we have a patient like that one, we will go for a tunnel osteotomy and we will use a circular implant. This patient was treated in collaboration with Dr. Pedro Huitian and Dr. Elena Lopez Alvar at Zygomatic Center, Vigo, Spain. We have perforated this bone and then place a round implant. This is our new Straumann ZAGA round implant profile. So let's play a little bit more. Imagine we have this patient now, and when we are guessing what to do, we will go to the sinus floor and we will measure here. We plant the implant for an intrasinusal path, and then we measure. This is 1.7. Do we think we are going to have problems? Do we think that this bone is going to disappear with time? Probably yes. So we have to foresee problems, and then maybe it's more convenient to practice a canal osteotomy instead of a tunnel osteotomy. Let's shift this implant outside, and then instead of getting 1.7 millimeters of bone contact, we get 6.3 millimeters of bone contact there. So what means is that if we are able to stabilize this implant, the amount of bone that will be in contact with my implant is going to be greater. If the design of this implant has some threads in this bony side, it will get integrated. And this is going to be a very stable sealing for the implant. But now we have to think that maybe we are facing a new problem, which is the soft tissue problem. So let's analyze this patient. Has the right side at the, this is a cutting of the position of 15, and this is the position of the second premolar of the left side. We don't have enough bone, so we are thinking not for a tunnel, but for a canal. So what we have done is perform is a canal on the left side and a canal on the left side, right and left side. And then we are placing this implant, and as you may see, this implant is a flat design, is not protruding, is closing this canal. So whenever we don't have enough thickness of bone, whenever we think we are going to have a problem, and this is our measures number 6, if alveolar thickness is insufficient, a buccal displacement of the coronal entrance is recommended. So the osteotomy is going to adapt a canal shape. And you may see the radiograms sometime later showing the sinus is very happy with the implant place. But this is the last case, the last patient, sorry. You see, this is the result, typical result of failing implant, failing teams. As you may see, this is our 3D model of the patient before starting. You see, it's transparent, totally transparent. You see, this is not transparent. This is a hole. This is another hole, another hole, another hole. It's like for the Swiss people, this is an emmental cheese maxilla. I will classify this. So let's go for the cuts. This is the cutting at the position of 1-3. You see, no bone, holes. This is the cutting at the position of 1-5. Very, very little bone. Cutting at the position of 2-3, very irregular anatomy, very difficult valleys and mountains, and almost the same at the position of the second left premolar. Very difficult. Those are very challenging patients, very challenging. Extreme atrophy. Extreme is a patient that has suffered for iatrogenic. Those patients will analyze you will, I mean, when this patient arrives to your office after having supported the failure of many surgeries, grafting procedures, with a denture retained by some paste, this patient is desperate. So what we may do, I think today we understand that we should be as much conservative as possible. So if we can avoid to make big holes over here, please avoid to make holes. You can just make the osteotomy that adapts totally to your implant position. Please do like that. Don't take away more bone that is necessary. Make a precise osteotomy and fix your implant there. Now we are very happy because we have this new portfolio of implants that can adapt to both situations, to the tunnel situation, and this is the round implant, and also to the canal situation, to the channel situation, and this is our flat implant design. So, and this is very congruent with ZAGA principles. We need not only to adapt the surgical technique to the anatomy of my patient, we also need to adapt our tools, our implants to the anatomy of the patient. This is very logical. So now I made a canal, but if I make a canal, how deep should I laterally sink my implant? I don't want my implant to be separated from the maxilla. So how deep should I laterally sink my implant on the alveolar crest? How deep? So you see this implant, we are not using any special instrument, just the classical round bar and the twist drill, but we take care a lot about this sinus lining. So we make this canal and we try to preserve the sinus lining, especially here, especially at the coronal part. So if you are going to get into the antrum, you make your antrostomy up, not down, up, as closer as possible to the zygomatic bone. And then we may place those implants that will very nicely adapt to our osteotomy. So we go again to the first picture, and let's see if we have this clinical scenario. I think we have understood totally. This is our challenge, very atrophic maxilla. The goal is to fix teeth there, and we have to balance between the two ways. So let's imagine the position of where I would place the implant, the position A. So it's going to be according to the ZAGA concept through the sinus. Intrasinus path is going to be safer for this patient. So whenever we can do that, place the implant in an intrasinus path. If not, what is preferable? If I cannot do that, what is preferable? I think we have to balance between risks. Balance. You can avoid problems. Is there an objective parameter to decide? I think the remaining alveolar anatomy, regardless the wall anatomy, is the most important parameter. Where the sinus entrance antrostomy should be located, I think as higher as possible, the higher as possible. It's just about bone millimeters of architecture, or may other factors influence the result? I think we have to keep in mind this is not a static parameter. This is not a static picture. It's a patient. It has maybe a periodontal history. It has habits. It has you or me. We have different surgical skills. So there are many other parameters that will influence in the resorption or in the creation of problems at that level. And with this last picture, I like to thank again, and I like to quote Sir Isaac Newton again, when he said, "If I have seen further, it is by standing on the shoulders of giants." I'd like to especially thank my private giants, which are located at the ZAGA Center's headquarters. This is the ZAGA team. I'm so proud of working with him. With this, I thank you for your attention. If you like to visit us, we have a very nice, very simple and nice website. And if you like to come to our Zygomatic course, please, you will be more than welcome. Thanks to